I think everyone who confirmed now is dialed in, Nigel. So you're happy to make a start?
Yeah, absolutely.
Fab. Okay, thank you so much for everyone for dialing in today. It's really great that you all could put some time aside this afternoon to join us. We really appreciate that. So we just wanted to take this opportunity. You know, AML19 has been open for 7+ years and with 18 and 17. So we really just want to take this opportunity to share the results where we are at the moment, and just to be able to thank you all for everything that you've done participating in this trial and helping us get to this point. So the plan for today is for Nigel is going to make a start and it's going to share the 19 results. Then we're going to move on. Nigel and Sylvie are going to look at the AML version 1 results. Then Richard Dillon is going to talk about what these mean in practice, and then Steve's going to go on and look at future trials and where we can see the results moving on from here. There will be some time at the end for some question and answers. So we've got quite a lot to cover today, but we will try and make sure there's time for some discussion at the end. So to get us started, Nigel's going to take us through the AML19 results.
Thank you, Joe. So I hope everybody can see my slides. Is that correct, Joe? You can see that?
Yes, yeah, we can see that.
Okay, great. So it's really quite exciting to be able to feedback some information to the investigators of the AML18 and 19 trials. We've given some preliminary data back on AML18 over the last year or so, but we've got more data now, more analysis, which Sylvie will present on MRD and genomic data. I was going to go through, I start with AML19, where we've really not fed back any results well, at all, but it's quite exciting now the trial is finished that we're seeing emerging data come through. This meeting, we decided to hold this meeting because, as you probably are aware, the annual review of leukemia meeting that took place every June, the Royal College of Physicians, hasn't taken place for the last 2 or 3 years, 3 years, I guess. For obvious reasons why, and so there really wasn't a forum for presenting back in results of the trial to investigators. So I thought that was remiss and that we should try and do this. So I'm going to present you some of the data from AML19. There's a lot emerging, there's a lot more to come, and there's follow-up as well. So to go back to the original AML19 questions, which were set really a decade ago now when we first started thinking about this trial to replace AML17. The original induction questions were about, we segregated 2 groups of patients at diagnosis, those who had appeared to have high-risk cytogenetics from those who had non-risk high-risk patients. And in the non-risk patient population, we were interested in studying a fractionated schedule of gemtuzumab, what we call GO2, and asked the question, was this superior to the classic MRC GO1 dose as pioneered in AML15? The second question was about combining the flag and GO induction, and does this improve survival compared to DA GO induction, which you could regard as a kind of standard of care? And for this purpose, we employed the classic Keith-Wheatley MRC 2x2 randomization, whereas patients could be randomized to one of 4 treatment arms in a 2x2 randomization, which has been shown to maximize information for clinical trials. And then finally, in the high-risk population, as you know, we were interested in comparing the, well, at that time, totally unlicensed drug, CPX351, and asking the question, was this superior to FLAG-IDA in poor-risk population, particularly in patients with adverse clinical features? And I'm going to present some of that data today as well. So just to remind you, the original version 1 flowchart. This is before we added the midostaurin pilot. Randomization between 2 schedules of GOs. I'm afraid this slide has got an error, which I should have corrected. It's actually it says GO3. It should be GO1, DA GO1, or FLAG-IDA GO1 versus FLAG-IDA GO2 and DA GO2. And then there was, as you know, there was a monitoring randomization post-course 2. There's a monitoring randomization for patients with a molecular marker, which is a carryover from AML17. I'm not going to present any data on that, although we're hoping to present some information on that later this year, potentially. Patients could become high risk at various time points, and I'll discuss that later on. But basically, there was 4 cycles of therapy, with either flag IDA and 2 high-dose Ara-C, or DA go, followed by DA, followed by 2 high-dose Ara-C. There was a randomization for consolidation, the amount of consolidation after 2 flag IDAs. This didn't recruit well, but we made it difficult to recruit because patients had to fulfill certain criteria. So the initial randomization, the 2x2 randomization, patients aged 60 to 60 excluded known adverse risk cytogenetics who could enter the high-risk randomization. So it turned out to be mainly favorable intermediate risk, although approximately 10% were found to have later have 10 adverse cytogenetics, and these are included in the analyses that I'm going to show you. So just looking at numbers, in the GO1 versus GO2 randomization 1049, DA versus flag IDA, there were more, but there were 1049 obviously in the GO1, GO2 randomization. And the reason why the number is greater with DA flag IDA is that we had problems with gemtuzumab supply in the early days of the trial. If you remember, we bought it from Pfizer in Japan. And at one point, post-Brexit, the pound plummeted against the yen, making it extremely expensive to purchase. So we had difficulties and supply problems there. Anyway, and then there are 635 patients into the CPX versus flag IDA randomization, which I present data from some of later. So the randomization, as you shown in the right-hand panel, which I've already gone through. So the outcome measures I'm going to show you from the standard randomization include event-free survival using ELN criteria, a failure to achieve a CR or CRI after 2 induction courses, death or relapse, that's hematologic relapse or molecular relapse, overall survival, and some MRD data that's been generated. So to go straight into the results, these are all patients, into that 1049 patients entering that randomization, showing event-free survival as defined. I hope people can see these curves. There's quite a lot of information here. So on the top left-hand panel is the randomization for the 4 groups: flag IDA, GO1, GO2, DA, GO1, GO2. And as you can see here, the groups separate into 2 groups, as it were, flag IDA in terms of ESS superior, and in terms of compared to DA. And this is shown more clearly in the top right-hand panel here, where we have the 2 GO schedules condensed into one. So there's over 500 patients in each randomization between DA and flag IDA, showing us a superior, highly significant p-value of 0.001 in favor of an EFS benefit for flag IDA. The bottom panel illustrates that there was no difference in outcome relating to DA, relating to GO1 or GO2 dose. So that's where the randomization is condensed into flag IDA GO1 and DA GO1 versus flag IDA GO2 and DA GO2. So we couldn't see a benefit for the higher dose of gemtuzumab, although we'll come on to some points about that later. So that's EFS. When we look at OS, overall survival, the survival curves on the top right-hand panel come together. So in other words, patients who in the DA arm could be rescued by more salvage chemotherapy and potentially transplantation, probably for the majority. And the left-hand panel mirrors that, as you can see, in terms of OS. And again, no difference between GO1 and GO2 in terms of overall survival. Now, if we just take those patients without a molecular marker, so this is looking again at EFS. This is patients who are NPM wild type, FLT3 wild type, that entered the high risk, the standard risk randomization. They had no molecular marker that excludes patients with core binding factor leukemias, it excludes patients with MLL. And you can see here the same pattern that we saw in the total population, with a flag IDA benefit, significant flag IDA benefit in terms of event-free survival in the top right-hand panel. So really very similar to what I showed you for the total population. And again, in terms of overall survival, there was no difference, as we saw in the total population. So if we look at the distribution of the genomic groups in this AML19 version 1 standard risk randomization, what I've just shown you is the 60-odd% of patients in the green who were patients without a molecular marker. But what I'm going to walk you through now is the results in the different genomic groups of AML in this randomization. Those who had a FLT3 mutation, so 23.4% of patients had a FLT3 mutation. The 10% of patients with a core binding factor, leukemia rate 21 or inversion 16. The 20% of patients with an NPM1 mutation. And then we'll also mention a small number of other patients as well, including those with the MLL fusions. So looking at these molecular groups, walking you through the results in FLT3 mutated AML, results in NPM1 mutated AML, CBFs, and MLL. So this is again taking you starting with EFS, event-free survival. And this time again, we can see here, this is for patients with a FLT3 mutant AML, TKD and ITD. Again, we have the four randomization here, the 2x2 randomization with the FLAG-IDA patients clearly benefiting, which is seen here in the FLAG-IDA versus DA randomization, a highly significant difference, p-zero value of 0.009 in favor of FLAG-IDA, and no difference in the GO randomization, GO1 versus GO2. For what it's worth, the FLAG-IDA GO1 arm was looking better than FLAG-IDA GO2, but that wouldn't be statistically significant. But overall, there's a benefit in terms of EFS for the patients receiving FLAG-IDA. So what about OS? And then for the first, and this time we do see the maintenance of a survival benefit for patients in the FLAG-IDA arm, which is shown in this top right-hand panel, a p-value of 0.047, showing that a FLAG-IDA benefit of about 10% at 5 years. So this is good long-term follow-up we're seeing here, but this is not short-term results. No difference in the GO dose, but unlike the total population, we are now seeing that subpopulations within the total group are behaving somewhat differently. So we see an EFS benefit and an OS benefit for FLAG-IDA in the FLT3 mutated population. So that is just really that top right-hand panel blown up for you to see. So the OS, 5-year OS, 64% versus 54%. This is all patients with a FLT3 mutation who entered the standard risk arm of the trial. Moving on to the other major genomic group would be NPM1 mutated AML, of course, which would include some patients with FLT3 mutation. And again, in the top left-hand panel, we see this clear segregation between the FLAG-IDA experience and the DA-GO experience, FLAG-IDA GO, DA-GO. No difference again in GO dose. And a big difference in EFS between, which is looks like about 15% difference in EFS, a highly significant p-value of 0.003 in favor of FLAG-IDA in the NPM1 mutated patients. Now moving on to overall survival, again, like the FLT3 mutated population, we see this that the OS benefit is maintained in the NPM1 positive population, which was lost in the overall population, which I showed you right at the beginning. So the an overall survival clearly superior in NPM1 mutated patients with FLAG-IDA. And if you're looking at 5 years, you're looking at a survival of about 65% versus towards 80% in favor of NPM1 mutated disease. Now that is here we are, this is got it out for you, 82% versus 64% in favor of FLAG-IDA with in the NPM1 positive group. Now, to go with that, you'll be very familiar that we stratify patients in the trial based upon their post-course 2 peripheral blood MRD status for those patients with an NPM1 mutation. And this is data generated by Chad Othman and Richard Dillon. I was going to say Richard Clark, Richard Dillon, looking at the proportion of patients that are MRD positive in the peripheral blood post-course 2, what we loosely call perhaps Grimwade positive patients. I think you'd be familiar with that term. So if receiving DA alone, just under 40% of patients who are actually, if you receive DA alone, will be MRD positive at that time point. In other words, higher risk. If you give DA-GO, it's down to 23%. So a big impact on adding gemtuzumab to DA in NPM1 mutated disease. But if you give FLAG-IDA alone, it's 14%, and FLAG-IDA Go is down to 12%. So overall 21%, but quite a lot of heterogeneity in terms of high-risk MRD positive disease, dependent upon what treatment the patient has had after 2 cycles of induction. And if we can even make this a little bit more complicated by breaking it down to whether the patients were FLT3 mutated or wild type. So this is all patients, obviously NPM1 mutated. So this left-hand panel here is the wild type, and the ITDs are here. And you can see here that there is, if you take the wild type patients, firstly, there are fewer patients who are Grimway positive. Overall, it's roughly half what we see with the FLT3 mutated patients. This is something we're familiar with from the Adam Ivy and David Grimway paper in New England Journal of Medicine from a few years ago. But we can see here the effect of gemtuzumab on the DA-Go. So DA-Go2, far fewer patients were NPM1 mutated, but with FLAG-IDA Go1 and Go2, it was even lower. And we see this same phenomenon in patients within the ITD, although DA-Go1, 50% MRD positive, but down to 28.5. So Go2 benefits DA, doesn't have any effect on FLAG-IDA. So we could say that FLAG in the NPM1 mutated population, Go is essential. If you're giving DA, you give 2 doses of Go. If you're giving FLAG-IDA, 1 is sufficient. So moving away from those 2 major molecular subgroups of FLT3 and NPM1 mutated AML into the core binding factor leukemias, favorable risk disease, somewhat different pattern here. Firstly, in terms of the 4-way randomization, you can see that here these are all pretty close together, except surprisingly, DA-Go2 not giving a great result in the CBFs. In terms of FLAG-IDA versus DA, we saw no difference in survival between FLAG-IDA and DA. And EFS, sorry, this is the EFS what I'm showing you here. This is the Go randomization. Actually, Go1 is sufficient for the patients with CBF, and that there's no added, we saw no added benefit from a higher dose of gemtuzumab. And if we look at overall survival, you can see here the starting, if you look at the right-hand panel, DA giving really good results with combined with gemtuzumab. The Go1 at the bottom here, the Go1 versus Go2 question, Go1 looking better than Go2, although that is not statistically significant. And this is the DA Go1, where virtually everybody who got DA Go1 was a long-term survivor. Finally, the smallest subgroup with a molecular marker and genomic group, we lumped together the MLLs. Now, I have to be, some of the MLLs would have gone into the high risk randomization, CPX versus FLAG-IDA, because they were high risk they had high risk cytogenetics, classically the 1119 translocation. There are others. So this is predominantly patients with 911, the most frequent type of MLL rearrangement. And what you really here, we see the same pattern as before. The small numbers of patients, we're looking here, a very small number of patients. I've been showing you hundreds of patients before. We're now looking at less than 50. So the curves are a bit all over the place. Sorry, I think I've leapt on. No Go benefit, no difference in Go, but here we do see a FLAG-IDA benefit, although the p-value is not significant, but it seems to be following a trend that we observed for NPM and for FLT3 mutated patients. So that, although, as I say, the p-value is not significant. In terms of OS, it comes together between FLAG-IDA and DA. So small numbers of patients, good results actually for 911. We need to look at the impact of transplant in all of these populations. And I can't share that data with you today because it's something that's all these analyses are really hot off the presses. So to try to summarize the standard risk arm of AML19, if we take overall, including those MLL patients, I don't know why I put ML including. Anyway, overall, significant EFS benefit, but no RS benefit with FLAG-IDA. No benefit from GO2 with FLAG-IDA. GO1 was with FLAG-IDA was optimal for MRD and survival. And if you look at the major genomic groups of FLT3 mutated AML, FLAG-IDA goes significantly through both EFS and OS compared to DA GO1 and GO2. The 5-year survival was 64 versus 54% with DA GO. How does that compare? Well, I'm not going to go through that now because Richard, I think, is going to try and put these results in perspective or what you might expect with more standard therapy that you're using at the moment with midostaurin or other regimens. But remember, there was no FLT3 inhibitor used in AML19. So these results, which I think are really quite good, 64% survival with FLAG-IDA GO without a FLT3 inhibitor. We really need to pilot this combination with midostaurin. I think Steve might mention that. NPM1 mutated AML, FLAG-IDA GO significantly improves EFS and OS compared to DA GO. 5-year survival is remarkably good, 82% with FLAG-IDA GO versus 64% with DA GO. FLAG-IDA, as I've showed you, reduced the number of high-risk MRD positive patients, a Grimway positive population. A DA GO improves MPM-MRD compared to DA GO1, but it didn't impact on survival. And that's probably explained by the fact that we intervene early with MRD-based signal intervention in those high-risk Grimway positive cases and get them to transplant after salvage therapy. So I think we're rescuing those patients that got DA GO1, which is why we're not seeing an OS benefit, but we're seeing an EFS benefit. Finally, for the CBFs, there was no FLAG-IDA benefit we observed, but DA GO1 is the picker winner, to coin an old phrase, with an overall survival of over 90%, which I think is good. Thank you. So that is what I'm going to show you on version 1 in the standard risk arm. But as you know, there was version 2, and I'm going to briefly update you on some results that we presented at EHA on the MIDOTARG pilot that many of you would have participated in, where patients were we combined the DA GO1 or 2 with with midostaurin following the first cycle of induction therapy in patients with an ITD or TKD. So the aims were to study the feasibility, the safety of combining these two novel agents, midostaurin with either a single or fractionated scale of gemtuzumab, using the DA 3+10 backbone. We incorporated an interim safety analysis by the DMC after the first 25 patients, and then the second 25 patients have been recruited to examine the incidence of grade 3 toxicities, and I can paraphrase that by telling you there wasn't an increase in grade 3 toxicities or VOD. In fact, there was very little. I think there's hardly any. I don't think there was any VOD compared to patients receiving DA GO alone earlier in the trial. And finally, to undertake an exploratory analysis of the impact of these combination on MRD with the patients who had an NPM1 co-mutation. So the MRD was looked at by NPM1 RT-qPCR guys. Post-course 2 MRD negativity in the blood, obviously looking at those proportion of patients that were still positive. And then we've looked at log reduction following each cycle of chemotherapy up to 4 cycles, and end of treatment bone marrow negativity as endpoints for the MRD. And as I say, we compared with these responses that we've seen with the pilot with those patients who received with NPM1 FLT3 mutated disease who received DA GO earlier in the trial without midostaurin version 1. So I don't really want to go through this, it's quite a lot. So basically the third bullet point, we recruited in a year, 185 patients were screened, 77 were enrolled into the pilot having a FLT3 mutation, 39 received GO1, 38 received GO2. Of those 77 patients, 59 had an ITD, 22 had a FLT3 TKD, and 4 had both. And at this time of this analysis, we had completed course 1 in 59 patients out of the 77. And further follow-up, as you're probably aware, is ongoing in this population of patients, and there will be another follow-up later this year. What about safety and compliance? I mentioned that briefly already, but compliance was good. DA-GO2, if you look at DA-GO2 column at the end here, the right-hand panel, 38 patients, compliance was 100%. So, you know, there was no problem in taking the midostaurin after the DA-GO. I mentioned that the DMC reviewed SAEs and side effects, serious adverse events occurring in the trial, and were happy with that. VOD didn't occur. There's a little bit of QTc prolongation, but that's not unexpected. And the 60-day mortality in both the GO1 and the GO2 midostaurin arms was 0%. And that obviously not on the left-hand panels is what we observed in the control patients who received DA-GO without midostaurin. So yes, it was well tolerated, I think. So if you're looking at responses in those patients that were evaluable, 51 of the 59 had achieved a CR. That's just after course 1. There are 88% of patients after course 1 are in remission. Slightly higher for GO2 than GO1, but I'm not sure that's significant or not. And this compared favorably with earlier in the trial. So this is looking at CR. Remember that patients will, about 10% of patients potentially will go into remission with a second course of induction therapy. So the fact it's these figures would be higher if we looked at overall response rate following the second cycle. So basically the regimen was well tolerated and gave high response rates. And this is the MRD data that Jad has generated. Looking at NPM1 copy number following each cycle of therapy, this is baseline. Following each cycle of therapy, in blue is the GO2, and sorry, bigger part. Okay, so let me start that again. The pink is DA-GO earlier in the trial, so this is comparing with the responses earlier in the trial, and the blue is the pilot with DA-GO midostaurin. So we've lumped together the GO1 and the GO2 results here, although as already explained, there is a differential response with higher response rates in GO2, but the numbers were the same of GO1 and GO2 in the proportion in the two populations that we've studied. And what this does show is that if you look at this, just the Grim-Wade positivity, this goes down with DA-GO midostaurin, so 74% were MRD negative in the pilot compared to 63% with DA-GO in version 1. And if we look at serial MRD following each cycle of therapy, it's lower with the medians are lower with the midostaurin component, such that if you look at end of treatment MRD negativity in the bone marrow, it was a DA-GO it was 60%, and a DA-GO midostaurin it was 81% in the pilot. So this obviously we will be following up MRD and following up the survival of these patients as time goes on. So to summarize the pilot, the addition of Mido to DA-GO was well tolerated, no evidence of increased toxicity, no evidence of reduced compliance, high response rate, encouraging evidence of MRD clearance, and reduction in the number of high-risk patients in post-course 2. Too early to assess the impact on survival, but we're doing that, and you will be pestered for follow-up, so it'd be grateful if people could bear that in mind. And I think Steve will talk about what might be proposed to take this forward. So you're probably getting fed up with listening to me, but I'm afraid you've got a bit further to go. I'm going to have a glass of water here, and I'm going to talk about the high-risk arm of AML19, feedback some information. Firstly, to say that although CPX is superior to 3+7, or has been shown to be superior in older patients with secondary AML, it's not compared with more intensive therapy in younger high-risk patients, like as in AML19. So our aim was to compare these two regimens in a high-risk AML and patients with MDS patients with high-risk disease, both of whom were identified as high risk at induction or high risk post-induction. And we also carried out this exploratory study, which I'm going to present today, of patients who had known adverse risk cytogenetics at diagnosis. And this is what I want to focus on, although I'm going to show you a little bit more from the other patients as well. And the endpoints that we looked at were overall survival, event-free survival, response, and the number of patients delivered to transplant and survival post-transplant, because clearly, this is a patient population for whom transplant is, I think the phrase is mandatory. So this was the high risk randomization. We discussed the standard risk, high risk known to be adverse karyotype could go into CPX versus FLAG-IDA. So that was the group that I'm really going to focus on. But you could become high risk post course 2 based upon the risk score or based upon response, refractory patients. You could go into the high risk randomization post course 2 based upon NPM1 MRD. And you could also go into the high risk randomization at relapse if you hadn't previously been high risk and entered that randomization. So the relapse randomization was only open to patients who have been standard risk up to that time point. So this is the flow chart of the consort diagram, the correct word, of the 636 patients who you recruited into this randomized question. And what I'm going to talk about there is broken down into various sections, but the section I'm going to start with are those patients who had known adverse risk karyotype at diagnosis, of whom 88 randomized to FLAG-IDA. CPX was 107. It should have been 2-to-1 in favor of CPX, but we had, again, supply problems with CPX early in the trial. There was also delivery problems, if you remember. There was a lot of problems about filters and God knows what, which caused havoc with some centres, but that's all ironed out now. So these patients with adverse risk cytogenetics, there were 195 that went in to this study, and they could receive up to 4 cycles of chemotherapy, either CPX or FLAG-IDA, MACE-MIDAC. Transplant was recommended early, if possible, but at least by course 2, or by course 2. And I should make the point that the CPX dose that we used in the second course of therapy in the CPX arm is higher than the SPC dose. For patients who are in remission, the standard dose is 65 units, I think, per meter squared on days 1 and 3. All patients in the CPX arm of this trial received a higher dose of 100 units per meter squared on days 1 and 3, whether they are in CR or not. So who were these patients? This is just a breakdown. And I think the point I want to make here is that there's quite a lot of older patients in this randomization. Although theoretically the cutoff of the trial was 60, we did allow older patients in fit for intensive therapy. And you will see here that in both arms, just over 25% of patients were over the age of 60. The median age was 55 in FLAG-IDA, 57.1 in the CPX arm. And you'll also note here that the breakdown of the type of disease was about 50% had what was thought to be de novo AML, 20% were reported as secondary AML, and just about 30% were reported as high risk MDS, more than 10% blast, and adverse cytogenetics. Hematological toxicity was actually greater with the CPX arm in terms of platelet recovery, 34 versus 29 days. But by course 2, sorry, that was in course 1. In course 2, the second FLAG-IDA was more toxic than CPX, despite the fact we used a higher dose of CPX in course 2 than is now the SPC dose. This FLAG-IDA is well known to be very toxic following the second course of therapy. What about response in these populations? What was interesting here, if you look at the overall response rate, if you look at the bottom line, maybe that's the best thing to start with. 75% CR rate with FLAG-IDA, 63, just under 64% with CPX, with a p-value that is not quite significant. But what was interesting was that the median duration of those patients that achieved remission with CPX was longer. It wasn't significantly longer, but it was 510 days versus 391 days for FLAG-IDA. So it would appear that with CPX, you were less likely to go into remission. But if you went into remission, there was evidence of a longer duration of remission. And the overall responses post-course 2 were mirrored by these post-course 1 response rates, there was more resistant disease in the CPX arm, 21% versus just under 15%. Course 2 treatment, what did patients get in course 2? The FLAG-IDA arm, they virtually all got FLAG-IDA because they got another course. So 54 of the 57 patients in the FLAG-IDA arm who got a second course got FLAG-IDA. In the CPX arm, there were 7 out of the 66 that got CPX actually received FLAG-IDA, and I think these were a pretty refractory patient to CPX who switched over to FLAG-IDA, but they, from our point of view of any analysis, they've been included in the CPX arm. So what is the survival? The top left-hand panel is overall survival, and there's no difference in overall survival in CPX and FLAG-IDA. And the bottom left-hand panel is EFS. No difference in EFS. But interestingly, in terms of relapse-free survival, when we did a multivariate analysis adjusting for NPM1 and FLT3 mutation status, there was a significant benefit for CPX in terms of relapse-free survival compared to FLAG-IDA. And this was so RFS was 3 years was 39% versus 29% in favor of CPX. We did look at the RFS by the type of disease. If you remember that there was a breakdown for patients with de novo AML, secondary AML, and high-risk MDS, and there appeared to be, in terms of that RFS benefit, it seemed to be in those patients with secondary AML or high-risk MDS rather than patients with de novo AML. And that potentially, I suppose, might be expected from the previous results with CPX. Transplant, there were more bullet point 3, there was rather more patients transplanted with CPX, 50% versus 43.9%, and that may be the explanation for the RFS benefit, because basically if you don't get these patients to transplant, they do badly. So getting them to transplant was one of the endpoints of the study. And patients who achieved a CR or CRI, more patients receiving CPX were transplanted compared to those who achieved a CR with FLAG-IDA. So that was 63% versus 49%. So it seems slightly easier to get patients who are having CPX to transplant. But there was no, if you got to transplant, it didn't matter what you had up front. Your survival was not different. And this is shown on the next slide here, where we have the CPX population in and the FLAG-IDA population of transplanted patients in blue and green, showing the clear benefit for allotransplant with survival, which I think is encouraging, 50% at about 3 years for high-risk AML, compared to the non-transplanted group, which, as you can see here, have done the median survival is less than 6 months. So to summarize this quite complicated bit of information, in this study, we've called an exploratory study. It wasn't powered to show a survival benefit, but it did show that CPX did not really improve response, OS or EFS compared to FLAG-IDA, but there was an improvement in the duration of remission and of relapse-free survival. And this benefit, as I've alluded to, is maybe due to transplant, more patients were transplanted, and also maybe due to this more intensive CPX dosing in the second induction course. Unfortunately, we don't have MRD to go with that. This RFS benefit is mainly apparent in patients with high-risk MDS and secondary AML on clinical grounds, clinical diagnoses, rather than with de novo AML and adverse cytogenetics. And the final bullet point is self-evident that we need to improve outcomes. But I really just want to focus on this slide to finish with on this section. Well, not quite finish with, but to wrap up this section in. Is some ongoing work, which I'm not going to give in detail, but we're doing genomic analysis of these adverse risk patients at diagnosis. And this is a slide from Jad on the AML19 patient showing that the most commonly mutated gene in about 35% of patients is not surprisingly TP53, ASXL1 in about 25% of patients, and then all the normal suspects, including a whole raft of secondary AML mutations. So we are really now in the process of looking at the benefit of CPX or FLAG-IDA in these different subgroups. And we're hoping to have data presented at ASH on this. I'm not going to show you anything at the moment, it's very premature, but we do think that we can pull out genomic groups with a benefit for CPX and genomic groups that don't benefit from CPX. So I think that the clinical diagnoses of MDS or secondary AML that I gave you earlier may be superseded by a genomic classification that will help us decide who to treat with these agents, providing we've got the information available. Right, I'm just briefly going to talk about some of the other high-risk randomization, not in detail as much I've gone through. You'll be pleased to know that 263 patients who are high-risk post-course 1 included a lot of FLT3 mutated patients, because these patients were recommended to go into the randomization and go on to transplant if they didn't have an NPM1 mutation. And to show you that CPX was not, although seemed to be a somewhat better signal in the upfront patients with adverse cytogenetics, we didn't see any evidence of a benefit over FLAG-IDA in this population in the post-course 1 high-risk population, where, although not significant, there's a trend towards a FLAG-IDA benefit, both in terms of overall survival, event-free survival, and relapse-free survival. So this mirrors the AML17 result, where we found that FLAG-IDA was superior to the combination of daunorubicin and clofarabine. It also seems probably to be superior, although I have to be careful what I say, to CPX. And finally, the other group I want to briefly mention is the relapsed patients, 119. Again, CPX FLAG-IDA randomization. Just to say, the median age of these patients was about, I think, about 55. Remember that the patients had to be in the standard risk randomization before they relapsed. They weren't allowed in if they'd already been in the FLAG-IDA CPX randomization. So these patients had not been high risk before the randomization. And that probably explains the fact that if you look at the breakdown, 94% were de novo AML and only 2% had secondary AML, and 100%, sorry, and 4% had MDS. So this is a more select population of patients, basically with favorable and intermediate risk cytogenetics. And here, firstly, to take you through the results, the CRI rates were, I think, remarkably good, 86% in both arms, FLAG-IDA and CPX. But overall survival was not significantly different. None of these differences in survival are different in terms of overall survival, the top left-hand panel, FLAG-IDA versus CPX. This is event-free survival, FLAG-IDA versus CPX, although that is just about reaching significance, 0.043. And this is relapse-free survival. Again, it's very difficult to see that anything is superior to FLAG-IDA in the relapsed favorable risk, intermediate risk population of patients. And this is if you really want to look at all patients that were randomized in the higher risk arm, all 600 and whatever it was, 35 patients, showing no difference in survival between CPX in the dotted line and FLAG-IDA. But I think the conclusions about the high risk arm is that we do see different treatment effects in different subgroups. There's going to be more data emerging as we break down the responses by genomic classification rather than, so just for example, to follow through patients with adverse risk genomics through the protocol and see how they did at each treatment point. So basically, the subgroups that I've shown you, these patients are very different from one from another. So it's not surprising we're getting different results, and the effects are variable within the subgroups. So one subgroup we seem to see a CPX benefit, and another subgroup we seem to see a FLAG-IDA benefit. But the effect of transplantation is clear. These patients I mentioned are transplant mandatory. And generally speaking, the subgroups with the most number of transplants did better. So in the CPX, in the upfront randomization, there were more patients transplanted with CPX than FLAG-IDA. CPX appeared superior. In the relapse setting and in the high-risk post-course 1, actually, I didn't mention it, but the transplant rate favored FLAG-IDA, and that mirrored the survival. Right, that's really going to taken you through AML19. In terms of, I just want to say that actually there's a massive amount of work still ongoing. All the genomic work is going to be emerging. MRD work is going to be emerging. and so it's going to be there's going to be a lot further information coming out, some of it fairly soon actually. We hope to have information on the genomic studies and in the high risk arm within the next few weeks. So I briefly, and I'm going to, you'll be pleased to know that I'm not going to stop speaking in the next 5 or 10 minutes, because I'm going to hand over to Sylvie Freeman, who I hope's on the line, and then Richard Dillon. And the aim here was to just briefly update you about AML18. I'm not going to talk about the current randomization because we did have a roadshow earlier in the year where we kind of went through that. But what I'm going to talk about here is some further analysis on the Go1 versus Go2 randomization, which I hope you will find interesting. So as you know, this study randomization was open for patients over the age 60 without known adverse cytogenetics, randomized between different schedules of Go, as in AML19 Go1 versus Go2. And this, I've got a slide showing the top recruiters. Pleased to say Nottingham came out top, University College Hospital in London and Wales in the top 3, thanks to many of the Danish centres, Odense and Copenhagen, for recruiting extra, and Aarhus, who all appear in the top 20. So 3 of the 5 Danish centres appear to have recruited well into this question. So who were these patients? Median age 68. 80% of these patients had thought to have de novo AML. In fact, we know that if you look at the secondary AML genotype, it's more like 50% have a secondary AML genotype, and about 50% have a de novo gene signature. In terms of cytogenetics, very few favourable risk in this age population. Majority were intermediate risk, but the adverse risk did creep in, of course, because these were patient cytogenetics weren't known at the time of diagnosis. So this data has been circulated before, in the process of writing it as a manuscript, showing no difference in CR or CR rate with course 1 with Go2, but more CRIs with Go2. And I'm not going to go into, because Sylvie's going to talk about that, but basically there was an MRD benefit with Go2, MRD negative Go benefit. And in terms of mortality, there was no difference. So this is the final analysis of the Go1 versus Go2 randomization that's just been updated this year. Overall survival, a p-value is 0.014, hazard ratio 0.88, but this is not significant in of Go1 versus Go2. However, when you do what we've called a sensitivity analysis, and for here we've excluded those 14% or whatever, those patients who had adverse risk cytogenetics, and we've also excluded those patients who didn't have adverse cytogenetics but had a TP53 mutation. There weren't too many of those, but there were some, because most of it associates with complex cytogenetics. And when you do that, and we feel this is a justified analysis because the aim was to analyze the Go1 versus 2 in the non-adverse risk group, we see a hazard ratio of 0.03, p-value of 0.046 in favor of Go2. I'm not sure if Sylvie was going to show this slide or not, but this, interestingly, when we looked at this effect by age group, if you're younger or 65 to, if you're under 60 to 65, if you're 65 to 69, there's a Go2 benefit. But this is lost if you're over the age of 70, and this may be due to toxicity, or we're not sure, or it may be that this population over 70s, there were very few transplants going on, and that may be important, as we will see. Because if we do a transplant analysis, and this is data that was actually has been presented before, the Kaplan-Meier analysis, sorry, I beg your pardon, the Mantle-Bayer analysis of transplant versus no transplant, showing an ongoing benefit for transplantation in this population, hazard ratio 0.75 in favor of a highly significant p-value in favor of allogeneic transplantation in CR1, as we observed in AML16 as well, of course, but this benefit probably is greater than we observed in AML16, and I'd also say there were more patients transplanted in AML18. The total population of patients transplanted was over 30% compared to 15% in AML16. I think Sylvie might show these slides, but what I'm going to mention, if she does, you'll see them twice, it won't do any harm. If we look at the survival post-transplant by what induction therapy you had, so did you have GO1 or did you have GO2, and you were transplanted. So this is dividing the transplant population into two, dependent upon their induction therapy, and you'll see here that this GO2 benefit is clearly present in the transplanted population. So GO2 is making you do better with a transplant. And Sylvia might explain why. But if you do an overall survival curve, this is looking at the whole population and censored for transplant, that benefit of GO2 over GO1 is lost. So what's going on here? I think Sylvie will illuminate. But to summarize the AML18 GO1, GO2 experience, there was a survival benefit for DA-GO2 in analysis confined to patients without adverse risk cytogenetics or TP53 mutations. This benefit for GO2 was not apparent in the older patients, however, over the age of 70. Stem cell transplant shows a clear benefit for RIC in CR1, confirming the AML16 result. Patients receiving GO2 have a superior survival post-SCT, and we are exploring the reasons for this. There is no overall survival benefit for GO2 if you censor for transplant, however, and the impact of genomics is to come, and I hope that I can hand over to Sylvia now if she's online.
Yeah. Thank you, Nigel. So I'm just going to share my screen.
I think I may have to get you to close mine down. I'm not sure.
Yeah.
I think I have to stop sharing somehow. If I can find how to do that. No, I'm not quite sure how I do that. I can see you. Whose screen? We're still seeing my screen, are we?
Yeah.
Nigel, just next to the sort of red leave button, there's a share with an X on it. If you click on that, it'll stop sharing the screen.
Let's click on that. Okay, I've clicked on that.
Perfect. That's sorted.
Fantastic. So I'll hand over to you, Sylvie.
Okay, so can people see my screen?
Yeah.
Yeah, okay.
Yeah.
So just to carry on from what Nigel has presented for the AML18 and fill in a bit more detail with the MRD. And it's worth thinking that although it's now very established that MRD negative remissions are a good thing, that they reduce the risk of death, actually when AML18 was being planned, the community, Nigel and the UK were ahead of the curve in incorporating MRD into the trial. And we were able to do that because not only did we know that MRD negativity was good, but that it had been demonstrated in AML16 that there was a significant difference in survival according to MRD status of patients in remission. And the other thing I'd like to highlight is that MRD negative remission is good post-chemotherapy, but we also know that patients who go into transplant with an MRD negative remission do much better. So the questions that were posed in AML18, the first one was, we knew that detectable MRD post-course 1 increases the risk of death. And the question was whether that could be improved by an MRD-directed course 2 intensification. And there's an ongoing randomization for this, which I'm not going to talk about. But importantly, MRD response provides a tool to give us an indication of early indication of treatment efficacy, and therefore to compare trial treatment arms. And as you probably know, the now published 2022 recommendations say that this should be included as a study endpoint. Now, we used flow cytometric MRD in AML18 as, first of all, it had been validated as a prognostic marker for older patients in AML16 after course 1, and also shown by the pie chart below, which was produced by Robert Hills with data from Guy's and Rich and Dillon, that in fact less than 30% of older patients have a qPCR marker such as mutated NPM1, and that was from data in AML16. So Nigel's given you the results for the randomization of GO1 versus GO2. And if you look at the breakdown of overall response, you can see there's a signal, there's a slight difference in the complete remission with count recovery and also the overall response between GO1 and GO2. But with MRD, we can have a look at this quantitatively, and we can also increase our measure of depth of response. And in the GO1, GO2 randomization, we received a post-course 1 accessible bone marrows in 72% of randomized patients. And obviously, it's important to look at the patients in whom MRD was missing for this randomization. And if you look at the bar charts, the orange are patients who did not achieve a remission after course 2, the grey is patients who achieved a remission after course 2 but not course 1, you can see that the clinical response profile is actually very equivalent in the patients with missing MRD data, although overall, not surprisingly, refractory patients were overrepresented compared to the remission rates we can see in the total cohort. So what about the patients with MRD data of GO1 versus GO2? And the box and whisker plot on the left shows what happens to the quartile reduction and the median reduction in GO1 versus GO2, with GO2 on the right. And there's a significant difference in the scale of MRD that's reduced. If you look at the table on the right, overall, the MRD negative rate, this is for all patients for whom a MRD sample was reduced, was higher in the GO2 arm by about 8%, and this was even higher when you look at MRD level less than 0.1%, which is what the ELN MRD positivity threshold is for flow cytometric MRD. And then if you look at the best response of those patients who had a complete remission with count recovery, there's a 11% reduction increase in that number of patients who received that response. So overall, the MRD response difference between GO2 and GO1 is 8 to 10%. So we actually have more information to look and dissect what's happening to patients by molecular subtype, thanks to molecular profiling, which was performed by the team in Oxford led by Parish Vyas. And here you can see sort of bar charts which are subdivided into molecular subtypes. For each pair of bar chart, it's the GO2, which is on the right, and the GO1 on the left. Again, this is looking at all patients in the randomization for which we had MRD data and molecular data. And the dark blue is the percentage of patients who achieved MRD negativity, and the section above that, the slightly lighter blue, of patients who received MRD remission at less than 0.1%. And there's heterogeneity, at least by eye, across these bar charts, and you can see that the greatest differential of MRD response is in the IDH mutated patients, IDH2 and IDH1, but there's also a difference for the NPM1 mutated patients, but not surprisingly, the lowest rate of overall response and also MRD response in TP53 mutated patients, and then the patients with secondary mutations like RUNX mutations. So this gives us an idea of what precision medicine can look like in the future, and it's worth noting that this can actually only be looked at by flow cytometric MRD, because it gives us an assay that we can apply across molecular subtypes without looking at specific mutations and clearance. So Abin Thomas at Cardiff has obviously performed a lot of this analysis and then looked at whether there was any correlation between the MRD reduction by molecular subtype and whether it actually translates into an overall survival benefit. And in this forest plot, I'm just going to point out in the methylation mutation subtype, which groups the IDH mutations as well as DMT3A, you can see that there's a overall significantly different difference in benefit for survival, which favours GO2. So there's a reduction of sort of over nearly a third. But you know, for overall, as shown by the survival curves by Nigel, GO2 is better. But again, there's a heterogeneity in that benefit. So the greater leukemia clearance from GO2 in IDH mutated patients does correlate with a significant overall survival benefit in the methylation mutation subtype. So Nigel's mentioned the results for the allograft in AML18, and in the setup of AML18, we had MRD directed treatment for patients who were MRD positive or not in remission after the course 2. But it was advised that allograft should be performed, if possible, for the MRD negative patients as well as the MRD positive patients. And the rationale for this is that although MRD negative patients had a significant benefit for overall survival, you can see by these relapse curves, which is, you know, supports data that's coming out now, that most older patients will eventually relapse, and therefore their best chance of cure is an allograft. So again, as Nigel has shown, when you look at the non-adverse risk group cohorts of patients who did not have adverse risk cytogenetics or TP53 mutations, their survival was significantly better for GO2. But that effect disappeared when the survival curves are censored at the time of allograft for patients who went to allograft. So that gave us an indication that allograft was playing a part in the GO1 versus GO2 benefit. And if you look at the survival in transplanted patients, 27 in this actual GO1 versus GO2 cohort, 27% of patients received a CR1 allograft in AML18 with and in these patients, GO2 provided a reduction in death of almost a third. So a very significant difference. My conclusions from this is that we can see that the efficacy, an early indicator of efficacy from MRD from GO2 compared to GO1, because there was a greater reduction of leukemia measured by flow cytometric MRD. That this is not, we're not limited to just looking at patients overall, because we've got the numbers and we've also got the molecular subtyping, and we can see that there's a difference in MRD response for GO1 versus GO2, which varied across molecular subtypes and is greatest for the IDH mutations. As I said, this is a precision approach to assess efficacy as an early indicator of treatment benefit. The effect on MRD corresponds, it reflects the survival benefit that we're seeing from GO2 in patients with adverse genetics. But the results also suggest that consolidation by allograft is necessary in this older patient population to basically make the most of the initial improvement in chemosensitivity and to convert that improved MRD clearance after first induction into significantly improved longer-term survival. And I just say, by saying that there's obviously more to come from AML18 and MRD. There's going to be sort of equivalent efficacy for CPX versus DAR GO2 randomization in this older patient population, and we may well see some of the things that are being observed for AML19. Again, similarly to AML19, we're going to have more data on which genetic subtypes have, an advantage for CPX or DAR with regards, outcome, but also, what type of mutations are being cleared. And that's thanks to a collaboration with Chris Hourigan, who will be doing high precision NGS MRD. And then finally, we will have the results of the randomization for benefit of MRD directed identification with these different options of patients who are MRD positive or not remission post course 2. And it should be, again, with the UK, we're ahead of other people, because this is the only randomization that's ongoing for the benefit of MRD directed intensification after induction. So that's me finished. I think Steve is going to take over now. Or was it Richard? No, Richard.
Is it definitely me?
I think so, but I'm happy to go ahead if
no,
not.
I can go if it's me.
Yeah,
I think I'm afraid it is you, Richard. Yes, I think we're all agog.
Agog. It's really wonderful. I'd just like to say it's really wonderful to see these results coming out after such a long time and so many people having put in so much work into these studies. So it's great to see such kind of high impact results coming out. I'm Richard Dillon from King's College London, and the purpose of my section is to put the results from AML19 into the context of other NCRI AML studies, but also other comparable intensive treatment studies, contemporary studies from internationally. So I'm going to focus on the following subgroups. First of all, FLT3 mutated patients, and I'm going to compare these results with results from the international RATIFY study, which was the randomized study comparing midostaurin with placebo in induction, but also with the UK NCRI AML17 section, which randomized different daunorubicin doses, which was 60 versus 90 milligrams per meter squared. And subgroup analysis appeared to show a improvement in the FLT3 mutated group. Then I'll go on to talk about NPM mutated patients, and the relevant study, well, the largest study really to compare for NPM is this German AMLSG 0909 study, which recruited in excess of 600 NPM mutated patients, and they were randomized between Mylotarg or not with induction chemotherapy. Third, we'll have a look at this standard risk group overall, which is all patients excluding the known adverse karyotype at diagnosis, so all patients that didn't go into the high risk randomization upfront. And I thought the most relevant cohort to compare this group with is the Alpha 0701 study from France. I'd like to review the results of the core binding factor patients and review these in comparison with results from previous UK NCRI studies, and then finally the MLL rearranged group. And the most recently published large study was actually a study from MD Anderson of 172 patients, and you'll see that their patients appear to do very substantially worse than the ones in AML19. So first of all, starting with the FLT3 mutated patients, and as you likely know, the RATIFY study showed that the use of midostaurin in induction chemotherapy with DA improved survival, and there was an absolute difference of 7% at 4 years in overall survival with this drug. And as Nigel has told you, in the first part of AML19, there was no FLT3 inhibitor use whatsoever. That was only in the pilot part at the end of the study, of which survival results have not been reported. So all the patients in this, none of the patients in this study had received a FLT3 inhibitor. Despite this, you can see that the survival outcomes of patients receiving DA and Mylotarg actually were equivalent to those of patients receiving DA and midostaurin. And furthermore, you can see that patients receiving FLAG-IDA actually had a greater magnitude of benefit over DA-GO than was provided by midostaurin over placebo. The absolute increase in survival benefit at 5 years was 10% with FLAG-IDA compared with DA, compared with 7% with midostaurin versus placebo. So when we compare DA-midostaurin with FLAG-IDA-GO, you can see that the median survival is not reached compared with 74 months in DA-midostaurin. And the 3-year overall survival is 68% with FLAG-IDA-GO compared to 54% with DA-midostaurin, representing a substantial 14% absolute difference in 3-year overall survival. So this is very significant. And furthermore, this is without any FLT3 inhibitor use. And if FLT3 inhibitors could safely be combined with the FLAG-IDA-GO regimen, and if we assumed that the absolute benefit of that was comparable to in the RATIFY study, we would be looking at overall survival potentially into the mid to late 70%, which would be unprecedented in terms of survival for this group of patients. And then the other relevant study to mention in terms of the FLT3 mutated patients is AML17 DA90 versus DA60. As you may know, this randomization did not show a benefit overall, but subgroup analysis suggested a benefit in the FLT3 ITD mutated patients, and the survival curves are shown here. And with the stronger dose of daunorubicin shown on the dotted line. Importantly, none of the patients in this randomization received neither Mylotarg nor a FLT3 inhibitor. So when we compare these results with the current results from AML19, you can see that the DA90 results are comparable with the DA-GO results from AML19 using the standard 60 milligrams per meter squared, suggesting that the use of Mylotarg takes away the need for daunorubicin dose intensification, which is good news for hearts all over the UK. And probably also suggests that this 90 milligram dose of daunorubicin is no longer relevant for any patient groups. And then secondly, and more importantly, when one compares the DA90 result with the FLAG-IDA-GO result, we can see again there's a substantial difference in 3-year overall survival, an absolute difference of 14% compared with DA90. Moving on now to speak about NPM1 mutated patients. And the relevant study, I think, to compare with these results is the AMLSG0909 study. This was a randomization of addition or not of Mylotarg to their induction regimen, which is called ICE, which is idarubicin, cytarabine, etoposide. The ICE and GO results are shown in the red line here. This is event-free survival. Overall survival for this study has not yet been reported. Event-free survival was not statistically significantly improved in this study, but however, you can see there was a trend to improvement with the addition of Mylotarg. When comparing these results with AML19 result, you can see the ICE-GO event-free survival is broadly comparable to the event-free survival in the DA-GO arm in AML19. And very strikingly indeed, when we look at the FLAG-IDA-GO arm in the red dotted line here, you can see this is very significantly improved in terms of event-free survival. So when we compare event-free survival between FLAG-IDA-GO in AML19 and ICE-GO in the MLSG study, you can see that the 3-year EFS is 72% compared to 55% in AMLSG. This represents an absolute increase of 17%, which again is very substantial. And as Nigel showed you, the EFS translated into a marked improvement in overall survival for NPM1 mutated patients. And in fact, there was an absolute difference of 8% in the 5-year overall survival for NPM1 mutated patients as a whole, suggesting that this should be a new standard of care for these patients. And of course, further analyses will need to be performed, but initial results from Charlotte's analyses suggest that the benefit of FLAG-IDA-GO is seen both in NPM FLT3 negative and NPM FLT3 positive patients, suggesting that this should become the new standard of care for all NPM mutated patients. Looking more broadly at the standard risk randomization as a whole, The relevant comparison here is with the Alpha 0701 study, which was the study that led to the approval of Mylotarg. And as you'll know from the very annoying blue tack forms, is that they used this regimen, which consisted a total of 5 doses of Mylotarg, both in induction and the first 2 cycles of consolidation. And this result, in prolonged follow-up, there was a event-free survival, but not an overall survival benefit for the addition of these 5 doses of Mylotarg into DA, although you can see that there was a trend to improve overall survival. So what's important to highlight from this is that even with a single dose of Mylotarg, actually, the results from AML19 are substantially superior to those in the Alpha 0701 study. When one compares the 3-year overall survival with a single dose of GO, this is 65% in AML19 compared with 45% in Alpha 0701. Of course, there's a significant caveat here that the patient ages were somewhat older in the Alpha study, but nevertheless, it suggests that we can achieve a similar benefit with a single or 2 doses of Mylotarg than with 5 doses, which really implies that there could be very significant cost savings for the health service in terms, as well as savings in terms of toxicity. Moving on now to speak about core binding factor leukemias. So the slide on the left shows that the overall survival for core binding factor leukemia patients has been climbing steadily over the past few decades in sequential UK NCRI trials. And this is thought largely to be an effect of the increasing use of Mylotarg again, which we know has a substantial impact on overall survival in the core binding factor patients. And this benefit is seen both in inversion 16 and 821, and its magnitude is greater than 20% in absolute terms. In terms of other treatments that have been tested in the NCRI trials, so this slide shows that FLAG-IDA compared with AID improved the relapse-free survival significantly, but actually had no effect on the overall survival for these patients. And a similar result was obtained with HiDAC. And I think this reflects a peculiar property of core binding factor AMLs, which is they tend to be characterized or have historically been characterized by having a relatively high relapse rate, as shown on the left-hand figure, which is the relapse-free survival for CBF AML treated with Mylotarg in AML 10 through 17, in which the relapse rate is approximately 40%. But also at the same time, high salvageability at the time of relapse, which was greater than 50% in the time period 2008 to 2012. So this means that although some treatments may have a significant benefit on RFS, it's difficult to improve in OS, and in fact, it appears that Mylotarg is the only thing that has done that. Another thing that we knew from previous NCRI trials is that core binding factor AML patients do very well with FLAG-IDA. The panel on the left is from Alan Bennett's JCO paper, looking at patients who received 2 cycles of FLAG-IDA and then 2 cycles of high-dose cytarabine without any Mylotarg. And you can see that for favourable risk cytogenetic core binding factor patients, their overall survival at 8 years was 95%. Of course, this is highly selective, as it only includes those patients who are able to receive all 4 courses of treatment, which with this regimen can be a tall order. Nevertheless, the outcomes for these patients in terms of survival for patients that are randomized to FLAG-IDA and high-dose cytarabine appear very good, and it was unclear what, if any, benefit adding Mylotarg to this regimen would be. So this was a principal question in AML19. And the result, somewhat surprisingly, as Nigel has shown you, is that there was no benefit for FLAG-IDA GO over DA GO in core binding factor patients. And in fact, if anything, patients treated with DA GO appear to do slightly better, although this was not significant. More reassuring still, the overall survival for patients treated with DA and 1 dose of Mylotarg was 97% at 3 years. which is astonishingly high, suggesting that DA-GO1 should be taken forward as the new standard of care for core binding factor AML. Another slightly surprising result from AML19 is, as I mentioned, core binding factor leukemias have previously been characterized by a relatively high relapse risk. Actually, we don't see that in AML19. And this is the event-free survival curve here. And you can see that there's no difference in event-free survival between DA-GO and FLAG-IDA-GO. But in fact, this is a matter of actually having leveled up the DA-GO rather than the other way round. And I'd like to suggest that this significant reduction in relapse risk that we're seeing here perhaps represents the fact that almost all patients are now receiving Mylotarg with their treatment, but it also might potentially reflect the careful monitoring that has been used in these protocols. And finally, to mention the MLL rearranged group. And as I mentioned, this is the most recently published MLL case series, and this came from MD Anderson, and there was 172 patients included in this study. And the overall survival curves you'll see here, and you can see that the MLL patients do very badly in the MD Anderson indeed, with a 5-year overall survival of only 20%. And this led the authors to suggest that all patients with KMT2A rearrangement should be considered adverse risk. Our data clearly argue against this, and you can see that the 2-year overall survival for MLL rearranged patients in both the FLAG-IDA-GO and the DA-GO arms is 75%. And I'd like to suggest that this reflects better risk stratification and also incorporating molecular monitoring in terms of treatment intensification and transplant decision making. So this is the conclusion of my section. First of all, about the FLT3 mutated patients. We saw that DA-GO produces similar results to DA-midostaurin, but we saw that FLAG-IDA-GO provides a greater magnitude of benefit over DA than adding midostaurin does. The benefit of FLAG-IDA is 10% compared to 7% for midostaurin. And that the addition of midostaurin to the FLAG-IDA-GO regimen really has potential to produce unprecedented survival outcomes for this group. For NPM mutated patients, we saw that FLAG-IDA-GO produced an absolute difference of 18% in 3-year overall survival over DA and GO, and this should be taken forward as a new standard of care for this group of patients. The benefits appear to be greater in patients with a FLT3 co-mutation, and again here the outcomes may be further improved by adding in midostaurin or another TKI. In standard risk patients overall, we saw that there was no benefit from using the full alpha schedule over 1 or 2 doses, and this will spare substantial cost and toxicity for future patients. In core binding factor leukemias, we saw that FLAG-IDA-GO was actually not superior to DA-GO, which should remain the standard of care for these patients. But we saw that relapses appeared to be significantly diminished in this current trial compared to previous studies, perhaps representing universal use of effective regimens and perhaps more careful monitoring. And finally, for MLL rearranged leukemias, in comparison to international cohorts, we see substantially better results in AML19. It's unclear why, but I would suggest that potentially early intensification and transplant based on both cytogenetic and MRD determined risk may play a role. Many thanks indeed for your attention.
Thanks, Richard. Yeah, we're just going to move on to Steve now. Oh, Steve, you're on mute.
Okay. My computer's going a bit slow at the moment, but can you see my slides yet? Okay, I'm just trying to get them into slideshow mode. Come on. Ah, there we are. Excellent. Yeah, so thanks everyone that's presented so far. I mean, you've heard about some really good developments and findings coming out of the national study. So I've got the challenge of, in the next few minutes, just trying to update you with what our current trial plans are for patients in the fit for chemotherapy group. Another alternative title, which is what everyone is asking repeatedly, is when is AML20 starting? And so I'm going to try to spend the first few minutes of this presentation just illustrating some of the challenges and complex machinations we've had, some to do with funding, some to do with how AML treatments have evolved, some to do with the pandemic over the last 2 to 3 years, which have made this rather a challenge. So I think this slide sort of sums up our current principles of what we would like to do next with clinical trials for intensive chemotherapy suitable fitter patients. So we want to continue to include attractive questions in partnership with the pharmaceutical industry that allows us to continue to access new drugs and that are future-proof, so that they sort of last. The questions are still attractive over the lifespan of the trial. Importantly, we don't want to limit patient access to the plethora of new drugs which have been approved through NICE over the last few years. As I say, we want to continue to build from the findings of the previous studies as presented over the last 3/4 of an hour. And it's important we don't duplicate the work of other collaborative groups, because the pharmaceutical industry aren't really going to allow us to do that in a way that they would allow their agents to be used in new studies. If the questions are already being asked by others, then it's not attractive for us to ask them as well. Which kind of feeds into bullet point 3, which is there's this increasing need that for studies to be funded, they need to generate registration quality data, i.e. Data of sufficient depth and quality that will potentially feed into drug approvals by regulatory bodies. And ideally, these need to be studies which probably recruit within a 2 to 3 year time frame, potentially, rather than our traditional 5 to 6 years. So that's something we need to be mindful of. We want studies, though, to remain accessible to as many of our traditional partner sites that many of you on this call will no doubt be representing as possible, as well as just the larger regional high recruiting centres. We want to incorporate, as we need to, fast turnaround genetic screening for all patients, because as you're finding, I mean, Sylvie presented the data on Mylotarg based around IGH1, IDH2 positivity. So increasingly, we're depending on fast turnaround and molecular genotyping, including next generation sequencing, to inform study suitability. And we want to continue to harness our MRD expertise, where we're well established, as Sylvia and Richard have just demonstrated in their presentations. So this is kind of where we were with AML treatment in the UK when the last generation of studies, AML18 and 19, launched. And it was a fairly traditional treatment algorithm. There weren't a lot of complexities, particularly within the intensive treatment schedule, but you can see how that has changed over the last 5 years. And this is kind of what we're faced with now when we're trying to design a new study that potentially fits all patients in the intensive chemotherapy suitable group. We've got FLT3, we've got potentially different drugs for patients with therapy associated and secondary AML. We've got the addition of Mylotarg in certain subgroups. And additionally, we've got this kind of encroachment from patients in the traditionally less suitable for treatment intensive options, where there's more meaningful treatments, which might lead to possibly some blurring of this division line between intensive and non-intensive treatment. So this is all something we've got to take on board when we're trying to invent new intensive treatment schedules. We've also got to be mindful of the fact that a number of the questions we may want to have asked in this subgroup of patients are already the subject of big collaborative, in the main European-based treatment protocols. So CPX versus standard of care plus or minus venetoclax, first versus second generation FLT3 inhibitor with standard chemotherapy, and also the addition of IDH1 and IDH2 inhibitors to standard chemotherapy for patients with those types of mutations. They're already recruiting, and in those circumstances, it's very difficult to interest pharmaceutical industry partners in allowing us to use their drugs in those particular types of studies. So I'm sort of getting our excuses in here already, as you can see. It's also worth being mindful of the fact that we do have sort of disparity with different trial recruitment sites. So this is a sort of histogram that illustrates across the AML18 study how different study sites of different sizes contribute to the whole recruitment of patients within this study. So you can see that, roughly speaking, across 90 sites recruiting, about 2/3 of the recruitment does come from the top 30 recruiting sites, which are big regional teaching hospitals generally, including, as Nigel mentioned earlier on in his presentation, some of our partners in Denmark and New Zealand, whereas just over 1/3 of the sites contribute less than 10% of the patients. So when we're thinking about much more study inspection visit heavy, more expensive to run studies, which have a lot more pharmaceutical industry buy-in with the means of generating registration quality data, we have to be a little bit careful about how many sites have the capabilities to run those types of studies. That's not to say we don't want all sites to be able to contribute to some of the studies we propose, but we have to be mindful of the fact there may not be any such thing as a one-size-fits-all way of running these studies now. So what are the other challenges before we get into what studies we've actually got planned? So there are these challenges with our traditional funding bodies, mainly third sector funding bodies, in terms of how much they're able to carry on running the clinical portfolio and how quickly we can get funding from these traditional sources. We've got these pharmaceutical industry demands in terms of their reluctance to invest in very long-term projects, their needs always to address the bottom line and potentially widen the approved indications for their assets. They don't want to duplicate existing studies, as I've said, and they want this kind of registration quality data, which allows them to go to the regulatory bodies and seek widened approvals for their drugs. In some cases, particularly with the new agents, there is the need to generate additional safety data before we can widen the studies out into a randomized intervention. And as I say, there is this blurring of margins between some intensive and non-intensive. What constitutes an intensive and non-intensive patient? And these kind of treatment philosophies, which are kind of bleeding together slightly in that middle group. And then there are some of the challenges of getting trial recruitment going again in the sort of peri-COVID era. So this slide sort of sums up the current state of play. We've got trials for intensive treatment suitable patients which are currently open. We've got a number of active plans for patients who are suitable for intensive chemotherapy. We've got a number of other study ideas which are under exploration, particularly some investigator-led studies that seek to build on where we've reached following AML18 and 19. And then importantly, there are also potential supportive care study ideas, including the PROPEL study, which is now funded by NIHR and is likely to open at between 50 and 60 sites. So that's something that is a sort of known funded study, which is likely to be moving forward in the next few months. So I'm going to, if you'll excuse me, I'm going to try to run through as much of these plans as possible in the next sort of 10 to 15 minutes or so, just to orientate you with where we are and why we're doing what we're currently doing. So Victor is Richard Dillon's study, and the reason for mentioning this, because it's an open study, but it's really to highlight how important it is we recruit this study to time, because it's such an important question to answer. So Victor is this comparison of standard intensive chemotherapy with non-intensive venetoclax-based treatment for patients over the age of 60. So it is with NPM1 mutated AML who would otherwise be suitable for intensive chemotherapy. So it is this intensive suitable population, but it's looking at whether the less intensive application of treatment with LDAC venetoclax is equally efficacious and can be used in this group of patients, and whether it is effective or not is likely to shape how we go forward, particularly for this NPM1 mutated group in the years beyond the Victor study. We would aim to broaden the indications for Victor, so we gradually address lower age groups and potentially look at more mutational subgroups if the data from the existing studies is supporting widening this sort of approach to younger patient populations and other mutational subgroups. So I'd really encourage I think we've just about hit the full number of sites that were going to be open for Victor. It's actually expanded considerably between the 20 UK sites that was the case when this slide was designed. So we'd really like to recruit to Victor over the next few months. Propel is the study which has just been funded by the NIHR. This is Steinman Stanworth and Janet Dunn's study looking at the application of a personalised prehab schedule to patients who are undergoing intensive chemotherapy to look at the impact that a sort of multimodal prehab intervention, including physical activity regimens, nutritional regimens and psychological regimens, combined into a prehab package to look at the difference that makes to these patients going through intensive treatment. So I don't have time to go into the Propel study in detail, but it's essentially looking at patients who have achieved first remission following their initial course of intensive chemotherapy, and then looking at randomizing them between standard of care and getting this personalized prehab package and seeing how that impacts on their treatment course beyond that, looking at measures of fatigue, but also looking to see whether it impacts on long-term outcomes, including quality of life and health economic outcomes. So this is a study which we're really keen may be suitable to be run by senior nurse PIs, such as specialist nurses or senior trials nurses at individual sites, and it's something which is going to potentially augment our existing trial portfolio, so patients can go into Propel as well as going into more interventional, sort of traditional drug intervention based studies. And just to get for the timeline for that, we expect that to be opening probably by the start of the first quarter of 2023 at around 50 sites around the UK. Next is slightly off-piste of this main presentation, but it is a number of years now since we had a first-line study run through the NCRI AML group for patients with a newly diagnosed acute promyelocytic leukemia. The last one we did was AML17, where we compared AIDA intensive chemotherapy and arsenic trioxide ATRA, and to a degree, as a result of that study, arsenic trioxide ATRA has become the mainstay of treatment approved by NICE for patients with standard risk APL. So what are we proposing to do innovation? Well, this is a study where we would like to compare intravenous and oral arsenic trioxide formulations in the treatment of newly diagnosed APL, and I've been working with Richard Dillon and Nigel Russell in the inception of this study. So the oral arsenic compound we propose to use, which is called Arsenol, is a compound which has been developed by partners in the Far East. It's been shown to have similar systemic bioavailability to intravenous arsenic, and it's been evaluated quite extensively in studies, initially in first relapsed APL. It's also been looked at in maintenance, and more recently it's been looked at in frontline use, firstly in combination with anthracycline, but more recently in a chemotherapy-free intense frontline schedule, where the patterns of clearance of MRD, clearance of the PML-RAR alpha fusion, have been very similar to what we've traditionally seen with intravenous arsenic oral ATRA schedules, with 100% of patients becoming MRD negative by week 26 of the oral arsenic schedule. There's also been publications by another group in the Far East, this Chinese publication, where they used the alternative oral arsenic treatment, which is really not suitable for Western licensing, called the Realgar Indigo Naturalis formula, where they compared that with intravenous arsenic ATRA and found it to be non-inferior, with non-inferior 2-year event-free survival, including molecular event-free survival. So this is the basis on which we've designed Ovation, where we propose to randomise newly diagnosed APL patients between intravenous and oral arsenic induction and consolidation schedules, and we'd look to recruit both standard risk, i.e. patients with presenting white cell count under 10, and higher risk with presenting white cell count over 10, with the caveat that patients with the higher presenting white cell counts do get 2 additional doses of anthracycline as part of their induction schedule. So this is a study in which it's powered on the basis of demonstrating non-inferior molecular event-free survival, but there are some very important secondary outcome measures, including health-related quality of life and resource use, where we expect to demonstrate significant superiority of using an oral-based arsenic schedule in terms of reducing hospital visits, day unit footprint, etc., and also improving quality of life for patients as they go through. So this study has been gone in for funding to NIHR, and we expect outcomes of the preliminary funding application in the next 2 or 3 weeks before potentially submitting a second line application with the hope, if this is funding, we would be rolling this study out potentially to all of the traditional partner sites around the UK and hopefully also Denmark and New Zealand by early to mid 2023. So what about other studies in frontline non-APL AML? Well, one of the agents that many of you will be aware of that's coming under a lot of attention at the moment is magrolimab, which is an anti-CD47 antibody, CD47 being a macrophage checkpoint that basically inhibits this do not eat me signal, which is expressed on AML cell populations, and by inhibiting that it leaves AML cells open to macrophage mediated phagocytosis. And so as a monotherapy, magrolimab didn't have a huge level of activity in AML as we demonstrated in the Camellia study, but in combination with hypomethylating agents, particularly in adverse risk AMLs, there has been some very impressive activity demonstrated with high remission rates with the azacitidine magrolimab combination, and then even more impressive with the triplet combination of aza-ven magrolimab as presented by Naval Dava at ASH last year. We are seeing very high overall response rates, including in the TP53 mutated patient subgroup. So I don't have time to dwell on this data in any depth here, but Gilead, who now own magrolimab, have a very active trial program, including phase 3 studies for magrolimab in AML. So they have this frontline study called ENHANCE-2, in which patients with newly diagnosed TP53 positive disease are being randomized between the aza magrolimab doublet and an investigator's choice of either intensive chemotherapy or aza-ven based treatment. And they also have another phase 3 study where they are now looking at, or proposing looking at, the triplet aza-ven magrolimab against aza-ven in older, less fit patients. So in amongst that mix, Gilead also agreed to allow the UK group to use the triplet in a randomized phase 2 study in which the triplet is compared with intensive chemotherapy in patients with what we're increasingly referring to as allo-mandatory acute myeloid leukemia. So this is in other words, patients with adverse risk disease as defined by ELN 2022, and also with patients with over 55 years with intermediate risk disease who we would also feel to be allo-mandatory, and this is excluding the NPM1 mutated subgroup. So the current design for this study, which is potentially going to be run through the newly established ACT/TAP network, would be for a study of 140 patients where they get randomized between essentially an investigator's choice of standard chemotherapy and aza-ven magrolimab, with a primary endpoint of event-free survival at 2 years. So this is quite an intense study, which is going to require the collection of a lot of safety data. And so the proposal at the moment is this is a study which wouldn't be potentially suitable for the whole network. It would be a study that would potentially recruit over 18 months at 18 centres, which would be primarily the traditional TAP sites, but with a sort of accelerated opening where we hope this study would be opening by the end of the first quarter of 2023. But there is the possibility that Gilead are very interested in at the moment of expanding this to a larger, more definitive phase 3 study in 200 patients plus, where the participation of a wider number of traditional sites would be potentially open for discussion. So there'll be updates on that coming through quite soon, we hope. There's also, as you know, a lot of interest in combining venetoclax with intensive chemotherapy up front in newly diagnosed AML. Andrew Wee published the data in comparison to with a DA schedule, and more recently a lot of patients have been receiving FLAG-IDA then through a number of schedules which have been published in a number of ASH abstracts and in journals now, particularly by the MD Anderson group. This is the slide from the MD Anderson presentation of the FLAG-IDA then combination from ASH last year, showing very high response rates in de novo AML, including very high MRD negative response rates, suggesting high depth of initial response to these then containing schedules. Now, there's very limited randomized data for these schedules at the moment. This was the sort of ubiquitous propensity score matched analysis where they tried to compare with historical studies essentially of a a FLAG-IDA type regimen, but those studies are now being mooted, and we've got to see where we fit into this. So we've been having a number of discussions with our traditional pharma funding partner Jazz about looking at the CPX or VIX then combination, and a proposed design that's now in advanced stages of discussion with Jazz is this so-called VIX-VEN protocol, where we propose to combine CPX venetoclax with a standard of care, UK standard of care intensive schedule for patients with intermediate risk disease. This is the proposed design at the moment. It would be a two-way randomized design between standard of care and CPX venetoclax, with again the primary endpoint being event-free survival. Encouragingly, AbbVie have now agreed to supply venetoclax free of charge for this trial protocol using a 14-day 400 milligram dosing venetoclax regimen, and there are advanced discussions with Jazz, and again the Accelerating Clinical Trials platform are in discussions with this. The number of sites is not yet absolutely specified, but it's likely to be somewhere around 30 of the higher recruiting sites that would be suitable for this study. Now, you've heard the AML19 outcome data being presented by Nigel and Sylvie, and clearly there are some discussions around exactly what the standard of care is going to constitute here. You've heard some very encouraging results from FLAG-IDA go in this group, and so it's not absolutely nailed on yet what the standard of care arm is in this study. So there are a number of bits of fine-tuning that are required for VIX-VEN. What about following on directly from the data that you've heard presented in AML19 in a way that could potentially lead itself open to recruitment at larger numbers of partner sites? You've heard, if we talk first briefly about the FLT3 population, as Nigel said I would, what has not AML19 already established? Well, it's established that combining midostaurin with DA Mylotarg appears to be safe, and it's also suggested that combining this sort of triplet approach may have superior MRD response kinetics as well. But you've also heard from Nigel that FLAG-IDA Go may have substantial superiority to DA midostaurin or DA Mylotarg as the cytotoxic backbone for FLT3 positive patients. So this creates quite a lot of challenges for us going forward in how we take this forward into a randomized trial design. So DA midostaurin is clearly what's approved at the moment as standard of care for this group of patients. It's not something which is particularly attractive to the pharmaceutical industry as things currently stand, and neither is combining this with a second generation FLT3 inhibitor particularly of interest to the pharmaceutical industry in terms of funding this sort of study approach at the moment. So what we've looked at here is a randomized addition of Mylotarg here to standard of care in these patients with FLT3 mutated disease, and also building in a safety run-in design for patients to also have this, I guess you could call it a quadruplet design of FLAG-IDA, Mylotarg, midostaurin for initially a safety run-in, but then potentially building in a randomised 3-way assessment that looks at this. I mean, it would potentially need to be a fairly large study. From a statistical design point of view, it would potentially need more than 400 patients, and then you're getting into recruiting over 4 to 5 years. So we could potentially, I think, if we did decide to go forward with this design, be interested in looking at more intergroup collaboration, potentially with some of the European groups, and we would need to confirm what the funding model is for this design. So this is something we're very keen to do, but it's something where some of the details really need to be confirmed in discussions amongst the AML working group in coming months. Finally, what about core binding factor leukemias? You've heard about how well core binding factor leukemias do with the addition of Mylotarg. This was from Robert Hill's meta-analysis back in 2014, but you've also heard how good the outcomes are currently looking from DA Mylotarg in the AML19 study. And we're beginning to think about whether it might be possible to think about potential ways of de-intensifying treatment for some of these patients with CBFs who are doing so well, a bit like you've seen happening with some ALL children's type studies. So these are data from the MD Anderson looking at their anthracycline-free flag Mylotarg regime, where they demonstrated very high early rates of response and also very encouraging early rapid depths of response if you go anthracycline free in these populations. Crucially, this isn't these aren't randomized data, these are historical data looking at sort of consecutive populations recruited over a number of years over at the MD Anderson. So it does potentially suggest a randomized study may be of interest in this setting. So this is a study we'd be interested in looking at, which is basically where we'd compare our standard of care, which you've heard is very successful, DA Mylotarg, with potentially looking at going anthracycline free and looking at flag go. We would probably need to demonstrate non-inferiority here compared to the good outcomes we're also seeing in this situation, but build in important secondary endpoints, including some quality of life endpoints, and whether we can demonstrate reductions in cardiac toxicity by going anthracycline free. And there is the potential also in this group, given our strengths in MRD, to direct some intensification of treatment to patients who demonstrate in the early stages of treatment that they are falling into the smaller group that are showing early suboptimal responses. So this is very much a work in progress at the moment. We know that it's not something that's of a great deal of interest to the pharmaceutical industry because some of the licenses and patents for Mylotarg have already expired or are about to expire, and we know that this is a relatively small patient number indication where we may need to bring in collaboration from other trial groups. So this is very much a watch this space, but something which the working group are discussing. So just a closing slide. I hope I've sort of tried to answer the question of when is AML20 starting. It may never be starting because I think the prospect of getting a single study which fits all of this and all the patient groups and all of the nice approvals into a single funding model is going to be, well, it's very difficult. And it's become a bit of a nightmare trying to answer this question in recent years. But that doesn't mean we don't have a lot of potentially exciting trial designs going forward for frontline treatment of patients who are suitable for intensive chemotherapy. It's likely to require imagination, and it's likely to require a mixed approach where we've got a non-one-size-fits-all approach where we're getting different funding strategies for different trials, and we're not necessarily opening all trials to all sites, and that's something which we do with a slightly heavy heart, but it's something which is probably not going to be feasible for all sites going forward. We've got Victor that's active and recruiting, and we'd really like you to continue to focus your efforts on recruiting NPM1 patients to Victor because it may lead to better things and more expanded indications going forward. We've got the Propel prehab study, which I think is quite exciting, and it's likely to lend itself well to senior nurses getting more involved as principal investigators, and that's something which is quite an exciting area moving forward. I'd like to hope we're going to have some positive news for you on funding of Ovation as a frontline APL study that can be genuinely open to all sites in the next 12 months or so. So we'd like to keep everyone enthusiastic about participating in that study, which has the prospect of potentially improving quality of life for patients with APL as they go through treatment. We've got these two studies which are likely to be funded and are likely to be the first two ACT platform supported studies, where we're going to be able to firm up on some of those details in the next 2 or 3 months. And there are a lot of very active discussions at the moment about how we open studies for some of the subgroups of AML patients where you've heard exciting response and outcome data emerging from AML19. But we've really got to seek to address this issue of how we fund a universal study registration platform and data repository where we can continue some of the things we're doing at the moment with sample banking, central mutation testing and MRD testing in a way that's kind of can be continued and is kind of safely funded for years to come, because we don't want to lose that strength which has been built up over so many years. And just to mention, there are similar discussions ongoing for the non-intensive patient group, the over 60s, which are largely based around Venn-based schedules, which are being loosely termed the Evolve platform, and Mike Dennis and Paresh Vyas are working very hard on, and I'm sure you will hear about in other contexts. So I've probably shot considerably. For those who are still on the call, thanks for your attention, and hope we can keep everyone enthused going forward. Thank you.
Right, Joe, to say a few words. Well, thank you to all the speakers. It was really brilliant. We scheduled 2 hours. I thought we might finish in 1.5 hours, but we needed both 2 hours. Both of the hours we allocated. I'm not sure if there's any questions for me. Or if people have questions, I think the best thing to do would be to go to email or to email the AML18-19 trials office. I think we've just about used up all our time, unless there's any burning questions for the speakers. I haven't seen anything on the chat line. So I think probably the best thing to do is to finish the presentations. I'm glad everybody attended. We had a really good turnout. I think there were over 200 people dialed in at least. And there's been some really excellent talks, some of which I shall go away and get the slides on from Richard and Sylvie. So thank you very much to all the speakers. Thank you for Cardiff for organising it. Thank you for all of you who put patients into the trials over the last 8 or 9 or whatever it is years. Thank you for your efforts, and you're still making efforts in recruiting patients as well. Oh, not recruiting patients, but following up patients. And recruiting into AML18, of course. Okay, and Victor. So at that point, I'll leave you and enjoy the rest of your afternoon. Thank you very much.
Thanks, everybody.
Thank you. Bye-bye.
Thank you.
Thank you. Bye.